Sarath sir, are you there? Hello. There is
Hello.
some network issue at Sarath sir's end.
Oh,
Please give 1 minute.
yeah, sure. Okay.
Hello?
Hello.
Yes, just 1 minute.
I don't see a way of finding out. That's you can give me 10 minutes, then I will tell you. I'll have to put it because
Sarath sir, are you there?
yeah, I'm here. Now I'm able to see the slides. Yes.
Sir, if you permit, then we can start.
Hello.
Yes, you're.
You can start.
Hello, sir. Am I audible?
Yes, you are audible.
Okay. Good evening, sir. I am Dr. Shobana, a second-year resident in radiation oncology from Dharamshila. Should I start presenting the case?
Yeah, please start. Good
Okay.
evening.
Good evening, everybody. Today's case presentation is on carcinoma of tongue. So the chief complaints and the history of presenting illness. The patient is a 55 years old gentleman who is a resident of Delhi and shopkeeper by occupation, who presented with a chief complaint of swelling in the right side of the neck since 2 weeks and a growth over the right lateral border of the tongue for 4 months. He was apparently normal 4 months ago when he started noticing an ulcer along the right border of the tongue that was painless initially, and it gradually started to progress in size. He also complained of mild increased sensitivity to spicy food since last 4 months and is currently able to take only semi-solid bland diet. He noticed mild swelling in the right side of the neck for the last 2 weeks, which was not associated with any pain or stiffness in the neck. There are no complaints of restricted or painful opening of the mouth, regurgitation, or halitosis. He did not complain of excessive salivation or drooling of the saliva. He did not have any complaints of pain or difficulty in swallowing, speech abnormalities, voice changes, loosening of teeth, or any loss of sensation over the chin. He did not complain of any bleeding from the oral cavity, difficulty in protrusion of the tongue, or facial edema. There were no complaints of shortness of breath, hemoptysis, cough, jaundice, abdominal pain or distension, any bony pain or tenderness, headache, nausea, vomiting, or seizures. Coming to the past and personal history of the patient, he had a history of cerebrovascular accident, a transient ischemic attack 8 years ago, with resultant mild right-sided hemiparesis. Otherwise, he has no other comorbidities like diabetes mellitus type 2, hypertension, hypothyroidism, coronary artery disease, or chronic obstructive pulmonary disease. His past history has no significant history of any chronic infections like tuberculosis or any other major surgeries. There is no history of any injury because of sharp tooth or ill-fitting dentures. Coming to personal history, patient is a non-vegetarian by diet. His bowel and bladder habits are normal. Sleep is adequate without any known history of allergy to any type of food or drug. He takes anti-platelet medication every day for his previous history of stroke. Coming to his addiction history, he's a chronic smoker with 1 pack-year smoking history of cigarettes for greater than 30 years, which he stopped since last 2 months. He's a known tobacco chewer with quid for greater than 30 years, but does not keep it in mouth throughout the night. And he has occasional alcohol intake history too. Coming to his family history, there's no significant family history of any head and neck malignancies in his family. To summarize my history, patient here is a 55 years old gentleman, a resident of Delhi and shopkeeper by occupation, who is a chronic smoker, tobacco chewer with quid, and an occasional alcoholic who presented with complaints of painless, non-healing ulcer over the right lateral border of the tongue in the posterior half for the last 4 months, with mild increased sensitivity to spicy food, which is also for the last 4 months, and a swelling that he noted in the right side of the neck for the last 2 weeks. So should I continue with the examination?
Yeah, we'll ask the question in the last. Please
Okay.
continue. Thank you.
Okay, coming to the examination, patient was examined gently in a well-lit room in a comfortable sitting position after taking proper consent and in the presence of a family member. On general physical examination, patient is conscious, cooperative, and oriented to time, place, and person with an ECOG performance status 1 and Kronofsky performance scale score was 90. He's a well-nourished gentleman on account of the BMI status of 23.4. On cardiovascular examination, both S1 and S2 heart sounds were heard without any abnormal heart sounds and auscultation. On examination of the respiratory system, auscultation showed bilateral equal air entry and normal vesicular breath sounds were heard. On per abdominal examination, palpation showed the abdomen was soft, non-tender, and there was no significant organomegaly that was identified. His blood pressure was 110 by 70 millimeters mercury in the right arm in sitting position. Pulse rate was 86 beats per minute in the right radial artery, which was normal in volume, and the respiratory rate was 18 per minute, and he was afebrile. I'll describe the examination of the oral cavity and the neck with pertinent findings in the coming slides. Examination of the ear, nose, throat, and scalp were normal. Examination of the cranial nerves 9, 10, 11, and 12 were normal. And there was no pallor, cyanosis, icterus, clubbing, or edema noted, and his gait was also normal. Coming to the examination of the oral cavity, on inspection, oral hygiene was poor on account of nicotine stains on teeth and stains on the tongue. Mouth opening was adequate, no missing teeth were identified, and tongue was moist. There was no halitosis. An approximately 3 to 3 centimeter ulcero-infiltrative growth was noted in the right lateral border of the tongue, more in the posterior half with rolled out edges and surrounding induration. It extends posteriorly to involve the retromolar trigone and involves the floor of mouth beneath, but does not cross. It does not appear to cross the midline or involve the right buccal mucosa or the hard palate. There was necrotic debris that is noted in the posterior floor of the mouth alongside and underneath the growth that was identified on the tongue. So these are some of the pictures that I could take of the lesion. Um, Coming to the palpation, on palpation, all the findings of inspection were confirmed. There was a 3 to 3 centimeter sized ulcero-infiltrative growth with everted edges and induration along the right lateral border of the tongue, mostly located in the posterior half of the anterior tongue, extending posteriorly to involve the ipsilateral retromolar trigone, and also involves the floor of mouth underneath with slough and debris. It does not cross the midline, does not involve the right buccal mucosa or the hard palate above. Openings of the parotid and submandibular ducts were noted in the normal locations. Coming to the examination of the neck, on inspection, trachea was central and common carotid artery pulsations were felt bilaterally at their normal locations. There were no visible swellings that could be noted on inspection in the neck. However, on palpation, the patient was palpated for any cervical lymph nodes for which he was initially asked to flex the neck, and palpation was done from behind. 1.5 into 1.5 centimeter cervical lymph node in the right level 2 was palpable, which was hard in consistency but mobile in all directions, and it was non-tender. Another another lymph node with similar findings, measuring approximately 2 into 1.5 centimeter, was also palpable in the right cervical level 3, just beneath the first node that was described, which is again mobile in all the directions but hard to touch, and there was no pain or tenderness. They were not associated with any erythema, induration surrounding them, increased local temperature, or pus discharge. So to summarize my case, patient is a 55 years old gentleman, resident of Delhi and shopkeeper by occupation with chronic smoking and tobacco chewing history, with a performance status of 1 by ECOG performance status scale, who presented with a painless non-healing ulcer in the right lateral border of the tongue, associated with mild increased sensitivity to spicy food since 4 months, and a swelling in the right side of the neck for the last 2 weeks. On examination, a 3 into 3 centimeter ulcero-infiltrative growth was noted in the right lateral border of the tongue, more in the posterior half, with everted edges and slough in the floor of the mouth, beneath it, extending posteriorly to the ipsilateral retromolar trigone without involving the buccal mucosa, hard palate, or the base of tongue. 2 lymph nodes were palpable in right cervical level 2 and 3, measuring 1.5 into 1.5 and 2 into 1.5 centimeters respectively, both of which are hard to touch but mobile in all directions and not associated with any pain, tenderness, erythema, induration, or involvement of skin or the surrounding structures of the neck. So the provisional diagnosis based on the history and physical examination is a 55 years old gentleman with a 3 into 3 centimeter ulcero-infiltrative lesion in the right lateral border of the tongue and 2 ipsilateral lymph nodes of 1.5 into 1.5 and 2 into 1.5 centimeters in cervical levels 2 and 3 on the ipsilateral side, will most likely be a case of squamous cell carcinoma of the right lateral border of the tongue. Clinically, T2 and 2B MX, and stage grouping would be 4A. Sir, I'm done with the slides.
So, what is your differential diagnosis based on history?
So any ulcer that that is present in the oral cavity could be most commonly in countries like India, could be because of tuberculosis. So it could be a tubercular ulcer, or that could be an ulcer because of other infective conditions like syphilis, or it could be because of a trauma. So a traumatic ulcer can also be a possibility. And then it could be because of a tumor also. And after ulcer also is a possibility, sir.
Okay. So, did you miss anything? Any other differential diagnosis?
Any infective conditions like any warty growths that could be present, maybe, but that is very rare in the oral cavity.
So there is a term called non-specific ulcer.
Okay, sir.
So just please remember, because one of the most common differential diagnosis based on non-specific ulcer is sorry, no, differential diagnosis for malignancy of oral cavity or tongue is
Yes.
non-specific ulcer. That is the most important one. See,
Okay.
tubercular ulcer, syphilis, these are all 3, 4, 5.
Okay, okay, sir. Yes,
Most
sir.
important, please remember non-specific ulcer. Okay,
Yes, sir.
please,
Yes.
you need to read about non-specific ulcer, and you should have definitely you should have a note about that.
Yes,
Okay.
sir. Yes.
Okay. And based on examination, what is your differential diagnosis?
On examination, it is looking like an infiltrative growth, and it is ulcerated, which was non-healing, and it is progressing in size also. There is presence of slough and debris in the floor of the mouth alongside the lesion. So it most likely will be a malignancy only. It has to be confirmed with a biopsy, but most likely it
Yeah,
looks like a
so
malignancy.
yeah, definitely. So you should be able to justify your diagnosis and never ever say carcinoma of oral tongue, because if you say carcinoma of tongue, they'll ask you, is there a biopsy proof?
Okay, yes, sir.
And rightly said, you have put as MX instead of M0. That is one mistake people do, because if you say M0, they'll ask you, was the chest X-ray done, ultrasound abdomen done?
Okay, yes, sir.
So that is one.
Yes.
And next question, pathogenesis of like, what is your carcinogenesis? What is the reason for the malignancy of oral cavity in this patient?
So this patient had a chronic history of smoking and tobacco chewing, and also
Mhm.
occasional history of alcohol intake. So the most likely risk factor in this patient could have been smoking and tobacco chewing. Smoking has so many carcinogens in it, which can lead to decreased mucosal immunity. And similarly, with tobacco chewing, especially with his habit of keeping it quid for a long time in contact with the oral mucosal contents, there can be conversion of carcinogens that can lead to development of squamous cell carcinoma in the oral cavity over long periods of time.
Okay. So can you quote one carcinogen in tobacco or quid?
I think nitrosamines is a common carcinogen that can lead to malignancy. One of the common
Yeah. So you
carcinogens.
should remember benzopyrin also. That is one common example they expect from you, benzopyrin. From
Okay. Sir.
okay, and you should know what is the quid. What is the content of quid?
Yes, so I think it consists of the betel nut, the betel leaves, the erica nut, and tobacco plus some lime contents.
Yeah. So excellent. So and one more thing is, what are the most common sites of malignancy in oral cavity, and why is that?
Sir, in India, the most common site would be buccal mucosa. Again, it is
Okay.
attributed to the quid habit that the Indians mostly have for tobacco chewing.
Okay.
And otherwise, it is the oral tongue that is most common in the Western countries, I think.
Okay. So in India, yes, buccal mucosa and tongue, yes. And why do you think that is so? Why oral tongue is coming into picture when the quid is being kept at retromolar trigone and
Yes.
buccal mucosa area? Why the tongue is coming into picture?
Um, Tongue is a very mobile organ, so probably because of that, it has extensive contact with all these carcinogens that are being circulated.
Anything? Any other explanation?
Um, Extensive lymphatic drainage of the tongue also may contribute to it, sir. So,
No, but why is it starting in tongue?
why is it starting in tongue? Maybe because of the mucosal lining that is easily
No,
disturbed.
I'll leave it. See, the reason is, if
Yes,
when a patient is having quid in his mouth, there is a lot of saliva, right?
yes, sir.
Where is the saliva pooling?
Um, in the oral cavity, contact with the tongue,
In the oral cavity, where
in contact with the tongue.
the lower part of the tongue, especially the borders,
Okay, yes, sir.
or it can accumulate in the buccal mucosa, GB sulcus,
Okay,
right?
yes, sir.
That is one reason.
Okay, sir.
And you don't need to say KPS score and ECOG score, both of them.
Okay.
Okay,
Just mentioning one would be
that
sufficient.
is one.
Okay. Yes, sir.
One is enough. And most important, general examination, you tell it, then tell it. Enter general examination. Okay. If you have not done it, do not say that. Okay, that is one thing we learned by experience actually. If you don't do and you just tell them, the
Yes.
questions may go in that direction, and it will
Okay.
be okay.
Yes, sir.
And the entire pickle, pallor, icterus, cyanosis, clubbing, everything you should know. Like how to grade it, on what basis I've done that. Okay,
Okay.
that
Yes,
is
sir.
one. And do you know the Christmas grading?
Yes, sir. Christmas is actually graded into grade 1, 2, and 3. So starting from grade 3, where the mouth opening is less than 1.5 centimeter. Grade 2 would be more than greater than or equal to 1.5 centimeter, but less than 2.5 centimeters. And grade 3 would be when the mouth opening is greater than 2.5 centimeters, 2.5 to 3.5 centimeter.
The next question will be, do you have a scale with you?
Sir, I think it's actually measured with calipers, but I did not measure it like that in this
Yeah,
patient.
so keep it simple. Use fingers. Three
Okay.
fingers, 2 fingers, 1 finger.
Okay. Yes, sir.
That will be easier. So that is one. And you have not mentioned DMF score.
Sorry, sir. What was that?
DMF score.
Sorry, sir. What is that about?
Yeah, that is a score which gives information regarding decay, missing, and filling teeth.
Okay. Okay. Yes, sir.
That you have to mention.
Yes, sir. Okay.
And second thing is, if you want to define the extent of the growth,
Yes, sir.
you should use teeth as the teeth as extent. So it is extending, it is present on the tongue, extending from 1.5 centimeter from the tip, from the first premolar to the second molar or something like that.
Okay.
Because they
Okay.
will ask you, if you have examined like that, they will ask you, was the tongue examined in extended position or relaxed position?
Okay.
Okay, you should always examine the tongue in relaxed. It should be inside the oral cavity.
Okay. Yes,
Okay,
sir.
that is one. And you said for neck examination, node examination, you said
Yes.
1.5 into 1.5 neck
Yes.
node. Did you use a scale for that?
No, sir. It was very small, but then the level 3 lymph node was slightly larger than that, so I had to give some centimeters.
My point, I'm just trying to make a point, because when you say 1.5 and 1.5 to the point, they'll
Yes.
ask you, did you put a scale and measure exactly 1.5?
Okay. So should we round it off, sir, or uh, should we use an instrument to measure? Or...
See, if you have used a scale, then you're safe.
Okay. Okay.
Okay. And you said regarding the consistency in the conclusion, you used the word touch. Rather than using touch, you should use consistency of the node is hard.
Sir, I cannot hear you.
Yeah, regarding the consistency.
Yes, sir. Yes.
Excuse, can everyone mute? Someone from Karnataka is talking. No, it's better. So
Yes.
you should be using for describing a lymph node, it should be consistency rather than touch.
Okay.
I think somewhere in the description you use the word.
Yes, sir. Yes, sir.
I think that's for history and examination.
Yes, sir.
Remaining everything is okay. I think someone has pointed out, traumatic ulcer also is the differential diagnosis, but in this condition, as there are no ill-fitting dentures, I think we can rule out traumatic ulcer.
Okay. Yes, sir.
Ideal should be, I think they're asking, a lot of people are asking questions. If you want, you can answer them right now or you can answer later.
Sir, I think ideal should be included in the examination, but I could not do it in this patient, so I did not mention it.
Okay. Fair enough. You should be able to justify what is the reason for not doing the examination. You should be able to justify.
Okay, yes, sir. This time it
You
was
can
because
use
of the
induration for
COVID.
palpation. Sorry?
This time I could not do the
Dr.
ideal
Shobana.
because it was actually because of the COVID situation. So the surgeons had to take the case fast
Okay.
and do the surgery.
I think that's a very valid suggestion. No problem. I think you can go forward. You want to go forward to the management?
For the induration on palpation, I think we can feel the thickening on palpation. So that is why I mentioned the word induration, sir. On palpation, not on inspection. Also, I could see the growth. Beyond the growth, there are some signs of inflammation and thickening that could be seen. So I mentioned it on
Hello.
inspection also that there is
Am I
induration.
audible?
Yes, sir. Hello. Hello, sir.
Hello.
Hello, sir. You're audible, sir. Am I audible to you?
Hello.
Hello, sir. Hello. Hello. Am I audible to anyone?
Yes.
Okay. Is Sharath sir there?
I think there is a issue. Just wait a minute.
Can you hear me? Hello.
Yes, sir. I can hear you, sir.
Yeah, please continue.
Sir, I mentioned the word induration on inspection because I could see some signs of inflammation and thickening and erythema that could extend beyond the
Your
margin.
voice is too low. Hello.
Hello. Yes, sir. Am I audible, sir?
Yeah, now you are audible.
Yeah. So the question was, can we use the word induration on inspection? So I mentioned induration on inspection.
No. Inspection.
Because... Okay, sir.
And granular examination, preferably don't mention that, because when you say granular examination, they'll ask you why was it done.
Okay. Yes, sir.
So if you are able to give some justification for doing that, then please go ahead. But unless it is a nasopharynx case, you don't need to mention granular examination.
Okay. Yes, sir.
The examination in the case presentation, you should keep it as simple as possible, because if you give as much as possible, you should decrease the information that you're giving them. If you give more information, they have more chance of going in some other direction.
Okay. Yes, sir.
Okay. So anyway, I think you can go forward for management. Then we'll discuss some other information also.
Okay. Sir, so most likely because it's first of all, I would like to confirm the diagnosis. So to confirm the diagnosis, I would like to go for biopsy of the lesion. A wedge biopsy will be done. And then to know the extent of the disease, I'd like to go for imaging, which could be in the form of a contrast enhanced CT scan from the base of the skull till the carina. And because it's a T2 lesion with lymph nodes up to level 3, checkup is usually not recommended. But if the patient has any symptoms, then chest X-ray, because lungs would be the most common site for metastasis, can be done. And if any symptoms are then ultrasound whole abdomen can also be done.
Okay. So, one point.
Sir,
It is
hello.
Hello.
Yes, sir. Sir, T2 because the lesion was approximately 3 into 3 centimeters. And the depth of invasion could not be categorized because it's still a clinical staging. So
So you said floor of mouth is involved, right?
I could see some necrotic debris and slough that is present in the floor of mouth.
But is there any ankylosing for the patient?
No, sir. There was no ankylosing.
Okay. So you have a T2, N2B
N2B.
lymph node
Yes, sir.
in a carcinoma tongue, and you want to do a wedge biopsy for confirmation, CCT head and neck for local staging and regional staging,
Yes,
chest
sir.
X-ray ultrasound for metastatic staging.
Yes, sir. Yes, sir.
So okay. So what is your management treatment? How do you plan to treat this patient?
So firstly, we can, because the oral cavity lesions, the primary treatment would be surgery. So we can review with the surgical oncologist after a multidisciplinary tumor board discussion. We can send the patient to a surgeon, and surgery would be the primary treatment. And based on the adverse features that we can see in the post-operative histopathological feature, then adjuvant radiation would be required with or without adjuvant chemotherapy.
Okay. So based on the imaging findings and everything, you have
Yes.
sent the reports to the surgeon. And do you think he will go for the surgery, or he will say, I want more information?
I think if there is significant involvement of the soft tissue, I think I require a CMRI face and neck rather than a CECT face and neck.
Okay. So you are in this patient, will you do a CCT head and neck or MRI head and neck?
Yes, sir. I think MRI would be a preferable choice because tongue will have soft tissue involvement, which could be better delineated on the MRI.
But what is the one finding which is pointing towards MRI rather than CCT? You should be able to justify your management.
Probability of finding soft tissues and the delineation of soft tissues is better, and we'll get the information about depth of invasion also in a better information on MRI as compared to CT.
You said that you not, I agree, soft tissue delineation, but one finding of your palpation was suggesting we should do an MRI. That is, flora of mouth is involved, or flora is going towards the flora of mouth. Any tongue carcinomas which is going near or towards flora of mouth, they would like to do an MRI, confirm the surgical planes are resectable or not, then only they will go for surgery. Okay.
Okay, sir.
That is one point you should remember.
Okay. Yes.
So I think chest X-ray and ultrasound, that's fine enough, fair enough.
Yes.
Okay. Sir. And the depth of invasion from MRI, it's not perfect regarding that.
Yes,
and you'll get information regarding the ankylosing query or not. But I think from the pictures you have provided, there is no significant ankylosing. You don't need to protrude the tongue out. Okay. So the next question is, what are the pre-malignant lesions in oral cavity?
So the most common would be leukoplakia, and some other conditions that can also be pre-malignant would be erythroplakia, oral submucosal fibrosis, and there's a rare condition which is hyperplastic candidiasis that can also over the time progress to malignancy.
Okay. Among these you have mentioned, which is the most serious one?
Erythroplakia is most severe, sir.
What is the risk of malignancy?
Around 40 to 50%, 40 to 60% is the risk of an erythroplakic lesion to progress to malignancy. 30 to 50, but yeah, that's in the ballpoint. Yes, sir.
Okay. Then how do you differentiate leukoplakia and fungal infection?
Sir, a leukoplakic patch is that which cannot be rubbed off when it is present, while fungal infection like candidiasis can be scraped off. It can be rubbed off from the oral cavity.
Okay, fine. Okay. So what is your surgical management? How do you want to deal with the lesion?
So surgery, most likely it would be a wide local excision for the primary tumor with the 3-dimensional margin clearance. And for the ipsilateral neck, it is preferable to go for a modified radical neck dissection.
Ipsilateral neck?
Modified radical neck dissection for the ipsilateral side of the neck.
It's okay. So you are saying that you will do a wide local excision plus ipsilateral MRND.
Yes, sir.
Okay. So what are different types of neck dissection?
So initially it was radical neck dissection. Then the extent of the structures that were removed were further reduced down to modified radical neck dissection, which is type 1, type 2, and type 3. And then there is also selective neck dissection where only a few group of lymph nodes are removed. So radical neck dissection is removal of lymph nodes plus several other structures like internal jugular vein, sternocleidomastoid, or the spinal accessory nerve in the neck. When we come to the modified radical neck dissection, it is type 1, type 2, and type 3. So in type 1, there is removal of the spinal accessory nerve. There is sparing of the spinal accessory nerve. In type 2, there is sparing of the spinal accessory and the internal jugular. And in type 3, there is sparing of all the three structures.
Okay.
And selective neck dissection is a selective group of lymph nodes that are removed. So it is either supraomohyoid neck dissection, lateral neck dissection, or posterolateral neck dissection, or central neck dissection.
Okay. So in this condition, in this patient, what will you do among these dissections?
So I think we can go for ipsilateral MRND type 3 because there is no involvement of any other local structures. We can preserve all the three structures, I think, sir. I'm not very sure.
Why not supraomohyoid?
Sir, in tongue, there is significant chances of skip metastasis that can happen. So we have to go down and remove the level 4 lymph nodes also.
Okay, fair enough, fair enough. Okay. Then I think there are some questions. You want to answer them?
I'll try, sir. So the one of it says wide local excision with bilateral selective neck dissection. Will that be the choice, sir?
No, what do you think?
I think we should go for ipsilateral MRND only because the gross adenopathy side has to be removed, and the opposite side, if required prophylactically, we can treat it with elective nodal irradiation.
There is no if required. Tongue is always bilateral.
Bilateral, yes, sir. Yes. Sir.
Always bilateral. Okay. And I think Dr. Abhishek has shown very important point. Reconstruction. What do you do for reconstruction of tongue?
We have to choose a site that has adequate blood supply and mobility because we have our ultimate aim for reconstruction would be to get back as much as speech, swallowing as much as possible. So that would be the aim, sir. And we also have to aim to prevent aspirations.
Yes, fine. But what do you, which flap will you use?
I'm not very sure, sir. Maybe radial forearm flap. I'm not very sure. I'm sorry.
That free forearm flap. F. So I think that's the best flap actually.
Okay.
Yeah. And yes, so you have finished surgical part, and now you come to the radiation part. What is the gap due between surgery and radiation?
The best time would be to start off within 4 to 6 weeks, immediately as soon as the wounds will heal off. So 4 weeks is a minimum gap that we have to give before starting, sir.
Good. Fine. So radiation. Okay. So radiation, what is the dose you want to give?
Sir, in the adjuvant setting, the dose would be 60 gray in 30 fractions at the rate of 2 gray per fraction. But if there is adverse features like ENE and or close or positive margins, then we can give a boost to the regions where these are present to an extra 6 gray at the rate of 2 gray per fraction again.
Okay. I think someone has asked you, RMT involvement, still go for surgery?
So RMT, because of its most posterior location, it is difficult to be accessed, but then with RMT, we can still attempt for surgery.
How do you decide attempt for surgery? What feature does it give you to go for surgery if RMT is involved?
We have to look for the pterygoid plate invasion, sir. I'm not sure, sir.
For RMT involvement, generally they would recommend chemoradiation. They will not even think about surgery. But yes, there are some surgical oncologists which who say that if you can get a clearance of 5 mm there, where shaving of the bone can be achieved, then still we can go for surgery. But not say anything about that. Please go with, if RMT is involved. If they ask you if RMT is involved, what will you do? You say it's surgically not possible. Go for chemoradiation.
Okay. Yes.
Okay. Then and one more thing, if there is positive margin, your answer should always be I will refer the patient back to surgical oncologist for an opinion regarding the excision.
Okay. Yes, sir.
If that is not possible, then go for higher dose of radiation.
Okay. Yes, sir.
And one more thing, if there is a positive margin, you will do radiation alone, 66 gray.
No, sir. With concurrent chemotherapy.
Okay, fine. So, what are your volumes? Radiation volumes.
Sir, the GTV would be the gross visible disease, both in the primary and the gross adenopathy that we can see in the neck. And
No, you have a post-op specimen. You have
yes.
a post-op tongue. What?
So for the CTVs, we have CT high risk, intermediate risk, and low risk. So in the CTV, 66 is that volume which encompasses wherever we have ENE or a close or a positive margin, which cannot be surgically resected. And in the CTV 60 is that
there is no positive margin here. No.
If ENE is present, then we will involve that in CTV 66, sir, which would be the high risk.
Okay.
If ENE is not present, then we start with CTV 60, and then CTV 54 to 56 would be the CTV low risk. So CTV 60 will be the volume that will encompass the gross adenopathy in the neck and the tumor, the post-operative tumor bed will be encompassed in CTV 60. And CTV 54 to 56 would be prophylactic irradiation that will go into the contralateral side in this case, because is the primary here.
So you are saying that you will not include the level with positive node in CTV 60.
Levels with the positive node and the primary and the nodes that were removed by the surgeon will be involved in the CTV 60, sir.
Okay. So the opposite will be
in the
54 to 56.
Yes, sir.
56. Where was it mentioned? 56. I have never heard 56. No.
Sir, it is given in phrase only. The 3 volumes are described, and low risk is described as CTV 54 to 56.
56.
Yes, sir.
56. Okay, interesting. I read about 56. Okay, so you have given radiation. You want to give radiation 60 gray, 54 gray to and opposite contralateral neck. What is the dose?
Contralateral, because here it is not involved. It will be in the CTV 54 to 56. 54, sir.
Okay. Fine. Hello, can you hear?
Sorry, sir, I lost you in the.
What is the technique you want to use for this treatment?
So preferably, if all the facilities are available, we can go for IMRT. Image-guided radiotherapy, IGRT, can also be used based on the financial condition of the patient and the availability.
Okay.
Because tongue is a very mobile structure and we want to protect some of the important structures like parotid that can lead to long-term complications. IMRT is preferable.
IMRT is preferable. Okay. So you want to spare some structures. Which structures you want to spare?
Parotid is the most important organ of concern here, sir, because it can lead to long-term xerostomia. And the spinal cord also.
Spinal cord, parotid. Okay. So what is the constraint for parotid?
So the mean dose for parotid should be less than or equal to 26 gray.
Okay. And what is the constraint for spinal cord?
Spinal cord Dmax would be should be less than 45 gray, sir.
Okay. So you're saying that what do you mean by Dmax? Is it Dmax or some other number is there? Some CC?
So the CC, I'm not very sure about the CC, but Dmax we call it because it's a structure that is in series. So by damaging one segment, the entire spinal cord will be damaged. So we have to make sure that the maximum
I
dose.
think Dr. Mohan Krishna has answered the question. It is 0.03 cc. Okay. So 0.03 cc should be less than 45 gram.
Okay.
And you said IMRT. Is there any data suggesting that IMRT is beneficial compared to 3D-CRT in carcinoma time or any head and neck carcinomas? Any paper?
Sorry, sir, I'm not aware.
The reason I'm saying is once you say IMRT, they'll ask justification. Okay.
Okay. Yes, sir.
Okay. And if you don't have IMRT, how do you want to treat this patient?
Then we can go for conventional radiotherapy, sir, where we can open the fields according to the field spacing that we would require. And the borders, should I mention the borders also, sir?
Yeah, definitely.
Okay. So the superior border would be around 1.5 to 2 centimeters above the gross tumor, and the inferior border would be at the level of the thyroid notch, and posterior border will be at the level of the mid vertebral body.
First, tell me what are the fields you will use.
We'll use two lateral opposed fields, sir, opposed lateral fields.
So you'll use only two lateral opposite fields.
No, actually, two lateral opposed fields for the primary tumor and the upper neck. And for treating the lower neck, we have to use a anterior field, APPA field, lower anterior neck field.
Yeah, lower anterior neck field.
Yes, sir.
So what is the dose you'll use for treating with the patient with 3D CRT or 2D? What is the dose?
I think 60 gray.
60 gray for
60 gray in 30 fractions, and if there is adverse factors, then we can go up to 66 gray.
50 gray, 60 gray is okay. What about the neck? How much dose will you give for neck? 60 gray for the primary and the lymph node. Okay, but the neck, how much do you want to give for the neck?
54.
54. Are you sure?
Sorry,
so
sir.
if you are using 54 gray,
Yes,
and you are using two laterals, how much dose will go to the spinal cord?
Okay, I'm sorry, sir. For the two laterals, we have to limit it at 45.
45. What is the dose per fraction you are giving?
At the rate of 2 gray per fraction, sir.
With 2 gray per fraction, do you think we can achieve 45 gray?
Let's see, 45, yes. 44.
44 or 46? Both are an acceptable answer, but keep till you can say anything 44 or 46, but generally they do 46. Okay.
Okay, yes, sir.
Okay. So then you have two laterals on lower anterior neck field. You have a node in level 2B of carcinoma. So how do you intend to treat level 2B with photon if the spinal cord tolerance is 46 gray?
That we can incorporate level 2B in the lateral opposed field only, sir.
But you can't give off more than 46 gray, na?
Then we can treat the rest of the dose with electrons, using electrons.
Fantastic. Off card, we treat with electrons the rest of the part, and then you need to deal with remaining. You can go with photons.
Yes.
If you are good with field matching and everything, you have a cobalt. You do 2D in your hospital?
No, sir. There's no cobalt here.
So have you done any 2D planning in your hospital till now?
No, sir. I don't know.
I'm just saying because some examiners will be from a cobalt setting or a linear accelerator where they have too much load. So they will be very good with 2D planning. So you should have at least some orientation towards 2D planning.
Okay.
Okay.
Yes, sir.
Fine. I think, yeah. So now tell me, what is your protocol for dealing? What are the acute side effects?
Sir, acute side effects mostly in this case would be in the form of oral mucositis, and there could be skin reactions also. So weekly management with conservative therapies would be sufficient to manage the oral mucositis. And if the patient is having grade 3 mucositis, then we can associate with bleeding also. Then we can stop the radiation, give him a break in the radiation till he slightly recovers with along with the conservative management, and then we can resume it off.
Okay. So when do you think mucositis will start?
Usually after the first 2 weeks of radiation, most
Why do you
likely.
think so?
Um,
Okay. That requires some radiobiology, but we'll come to that later. And one more thing, I don't know how much longer you want me to go, because radiation is a quite lengthy discussion, and over that we have not even gone into chemotherapy. Do you want me to go on, or you want me to stop the discussion here?
Sir, chemotherapy is not prepared much. I can do it in the next class.
Yeah, no problem, because see, I think you are a second year
Yes, sir.
resident, right? Yeah, so I don't want to go too deep into radiation and its side effects and everything. But till now, you have done very good, actually.
Okay. Thank you.
Second year to give a presentation so properly, and you have covered majority of the aspects of academic presentation. But yes, radiation surgery, you need to go deeper.
Yes,
Okay.
sir. Yes, sir.
Only one word, actually. This is what I was taught. You should be able to explain every word you utter.
Yes, sir. Yes, sir.
If you can do that, now very clear you, then it will be a cakewalk. Okay.
Okay.
And most importantly, DNBs will be hammered a bit more during examination. So we need to put more effort
Yes,
for
sir.
reading. Okay.
Yes, sir.
Anyways, that is there. I think you want me to you want to answer the questions. Some of the questions they have postponed, posted in the group.
I'll try, sir.
I think someone has said xerostomia. Anyway, it doesn't matter. We can discuss that on WhatsApp group itself. There is no point in continuing the class. But
Okay.
Dr. Shobana, for you have done pretty well. But I am telling you again, this is not the examination how it goes, because
Yes.
they will not be so soft. They'll hammer you like anything. But
Yes.
from that point of view, you have done very good, actually.
Okay. Thank you, sir. Thank you, sir.
Thank you.
Thank you so much, sir. Thank you. Hello. Hello. Dr. Navneet, are you there?